All right, it's time for heart blocks, which is by far my favorite dysrhythmias. They're super fun. They're like doing a logic puzzle to me. So heart blocks are divided into categories, which are first degree AV blocks, second degree AV blocks, and third degree AV blocks. And they get more severe as they go down. So first degree AV block, not that big of a deal. Patient doesn't really have any symptoms unless it's like super severe, but really nobody has any symptoms. Second degree AV block, starting to get a little bit more serious. We have two different types of second degree AV block. We have a Mobitz 1 and a Mobitz 2. This is where the dividing line happens. Mobitz 1, still pretty benign, not that bad. Mobitz 2 and down, now we're starting to get into difficult territory. And the reason is because Mobitz 1 and first degree AV block, these things are occurring supraventricularly. And so we're going to learn that ventricular dysrhythmias are more life-threatening, supraventricular dysrhythmias not so life-threatening. So Mobitz 1, okay, are you hanging in? Just to make it a little bit more complicated, Mobitz 1 is also called Winky Bach, which is like one of the best names ever. And we do in fact call it Winky Bach. Hardly anybody calls it Mobitz 1, we call it Winky Bach. So Winky Bach, super fun, not that bad for the patient. So it's actually kind of cool when you get a Winky Bach. Mobitz 2, however, which is also a second degree AV block, Mobitz 2 is a little bit more serious of a situation because Mobitz 2 is now moving down into the bundle of His, and the bundle branches were now in ventricular territory. And we don't like that because that is a ventricular dysrhythmia and that can be life-threatening. And then the dreaded third degree AV block. Third degree AV block can definitely be life-threatening. So it gets worse as you go down. And the reason that these are AV blocks is because as you start in the A's and you go down to the V's, there's some kind of delay or total block occurring for the transmission of that current of electricity. So starting in first degree AV block, there's just a slowing that occurs on the way down. Starting in second degree AV block, some of the beats don't make it from the top to the bottom. Some of them do, but some of them get blocked and don't make it from the top to the bottom. And in third degree AV block, none of the beats make it from the top to the bottom. Not one electrical impulse makes it from the sinus node all the way down to the ventricles. Not one. So you can see that third degree block is bad news. And you're like, well, aren't they dead? Well, I'm going to show you how that works. It might be different than you're thinking, so I'll show you how that one works out. Okay, but let's start with first degree AV block where everything is still fine. So on first degree AV block, the sinus node fires electricity. It goes down to the AV node. The AV node holds it, and then it holds it a little bit more, and then it releases it down. Sinus node fires, AV node holds it a little bit more, and then sends it down. Sinus node fires it, AV node holds it a little bit more, and sends it down. All right, you've caught on, right? So the PR interval is prolonged, but all the PR intervals are the same. The AV node holds it too long, but it does it the same way every time. Okay, so what you're going to see on this strip is you got a P, just like you're supposed to have. You got a PR interval that is too long. Then your QRS comes. Now from the AV node down, it's just normal business as usual. So QRS is just normal. Everything's normal. The only thing that's not normal is this line is too long. The PR interval is too long. The P wave is too far away from the QRS. But the thing is, like, every one is the same. So let's let's just use our imaginations to imagine that I'm drawing all the waves the same every time. Okay, so this one's the same. They're all the same. They're all the same. So when you look at this strip and you say, is it regular? And you'll be like, yes. Okay, what's the rate? And you're like, oh, 72. And you're like, is there P for every QRS? And are the PRs all the same? And you'd be like, yes, yes, yes. And then as you do your measurement of how many boxes it is, it's more, the PR is greater than 0.20. And you're like, whoops, PR is too long. And you probably already eyeballed it, and you're like, why is that P so far away from that QRS? No business. So it's a delay. That's it. That's a first degree AV block right there. It is sinus rhythm with a first degree AV block. Because remember, if there's one P for every QRS and all the PRs are the same, then that's sinus rhythm. So we're going to say sinus rhythm with a first degree AV block. How does the patient feel? They feel fine because they're in sinus rhythm. Do they get atrial kick? Aha, that's an excellent question. They probably get it until there's a certain point where now the P is so far away that the timing is messed up and the valve has already closed. So if their PR is like 0.22, they could have been born with that, had it their whole lives. They get their atrial kick, that's how their heart works, and they're fine. If the PR is like 0.32, they probably don't get atrial kick. So it just depends on how far away the P is. And if they have really long PR intervals where this P is all the way over here starting to get on top of this over here. So let's say they have a faster rhythm. That could be a problem. So let's say their heart rate is a little faster and the next P is starting to occur there. And then they have a T and the next P is actually on the end of that. And then they have their next T and then the P is actually on the end of that. Okay, well that's a problem because we don't want T's to land on the last 1/3 of your T wave. No P's on your T wave because you could go into V-fib. So that'd be bad. A lot of people, as they Brady down and everything gets spread out, they develop a little tiny bit of a first degree AV block. A lot of people, as we put them on DIG, we put them on cardizem, we put them on beta blockers, and we slow their heart rates down. As a side effect, they develop a little tiny touch of a first degree AV block. But it's really kind of like a drug side effect. As long as it's small, we just let them have it. And that's okay. So if they have no symptoms, then we don't need to do anything. So we watch it and make sure it doesn't become anything worse. So that's really the treatment. We become aware of it. If it's the first time it's ever happened, then they might run a 12 lead just to have it in the chart. And then we, of course, get a set of vital signs and we, of course, report it to somebody. And then if they're asymptomatic, then we do not need to do anything to them. That's first degree sinus rhythm with a first degree AV block. Second degree AV block type 1, or Mobitz 1, or more commonly known as Winky Bach. Okay, what happens in Winky Bach is your AV node is beginning to fatigue. So the sinus node sends down an impulse. The AV node holds it, releases it to the bundle branches. Next impulse comes down, AV node holds it, releases it down. Next impulse comes down, AV node holds it, releases it down. Next impulse comes down, AV node just blocks that one, takes a rest. Perks back up. Impulse comes down, holds it, releases it. Impulse comes down, holds it, releases it. Impulse comes down, holds it, releases it. Next one comes down, just blocks that one, takes a rest. So the hallmark of Winky-Bach is PR intervals that are getting longer and longer and longer until eventually you get a P that does not have a QRS after it. So one gets blocked and then the pattern resets. And I just did where you had 3 that made QRSs and 1 that got blocked, but it can be any pattern. You could conduct 2, block 1, conduct 2, block 1. You could conduct 6, block 1, conduct 6, block 1. But Winky-Bach only ever blocks 1 per cycle. There's only ever 1 lonely P per space. So you will have a P, a QRS, and a T. Then the next P is a little bit further away. The QRSs look the same though, because from the AV node down, it's all the same. And then the next P is even a little bit further away. And then the next time you get a P and then a space. And then you go back to what the first beat was. The cycle starts over. Okay, so when you first look at the strip, what people usually notice is either groups of 3 going by, or groups of 2, or groups of 6, or groups of 8, or whatever it is. But groups of 3 or groups of 4 is really common. Groups of 3 is very common. Or, depending on, are you a glasses half full or are you a glasses half empty? This could be like a personality test. Other people notice this gaps going by. So you notice group beating or you notice the gaps going by. And when you notice a space, I always look in that space to see, is it just a pause, just a flat line with nothing in it? Or is there a little P in there all by itself, a little lonely P that got blocked? Because if there's a P all alone, that's not a pause, that's a heart block. And there is a P in here all by itself. So this is some kind of a heart block. Darn it. So how do we determine what kind of heart block something is we measure the PR intervals. So I'm going to measure these PR intervals right next to each other. And what I notice about them is that they're getting progressively longer. And then I get a P that has been blocked. And then the cycle starts again. And I notice that the first one after the space is just like this one. And the second one over there is going to be like this one. And the third one is going to be like this one. And then there's always a P alone. So it's the same cycle over and over and over. That's Winky-Bach. It's pretty rad. It's pretty cool. P's getting longer, 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 block 1. Longer, 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 block 1. Longer, 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 block 1. The P's will all come on time. So like if the P's are this far apart, they all march out. They're right on time. There's nothing wrong with this P. It's not early, it's not weird, it's not a bad P, it's a perfectly good P. There's no reason why it shouldn't have made a QRS. That's a heart block for you. So that's Winky-Bach. In Winky-Bach, the patient still gets almost all of their heartbeats. So their pulse is very good. The rate is usually in a sinus rate. As long as these PRs aren't too bizarre, they probably get most of their atrial kick, so they are usually asymptomatic. The problems are above the ventricle. The problem is usually in the AV node somewhere. So it's a supraventricular conduction problem. It is not life-threatening. It is almost always transitory, so it will eventually wear off. like the most common people who get it are people who have had inferior wall MIs, which is kind of the smaller type of heart attack, that people have good outcomes from that type of MI most often. So we'll just do all the treatments that we do for their heart attack, support them, and treat the underlying cause, keep an eye on them, and then this will probably resolve as we treat what their underlying problem is. So we just watch it, make sure it doesn't become a worse kind of block, but it hardly ever does. It almost always resolves. And I'll tell you the truth, if they are on a telemetry floor, they don't even have to go to ICU if they get this kind of heart block. They can stay on a lower acuity floor with a Winky Bach. We don't have to give them any drugs. We don't have to put them on a pacemaker. We just watch them, treat the underlying thing, and support them. All right, moving on to Mobitz 2. Mobitz 2 also has another name, which is classical block, but everybody just calls it Mobitz 2, so I'm just going to put Mobitz 2 up there. Mobitz 2, we're getting into serious business right now, because Mobitz 2 is moving down into the ventricles, and it can be down in the bundle branches a little bit. In Mobitz 2, why it's also a second degree block is because we're going to have some P's that don't have a QRS after it. That's what it has in common with Winky Bach. But we could have more P's that don't have a QRS after it in Mobitz 2. We're going to have some kind of pattern where we have some P's with a QRS and then some P's that don't have a QRS, just lonely P's. And it really can be almost any pattern. Like you could have conduct, conduct, block, block, conduct, conduct, block, block. Or you can conduct 3, block 1. Conduct 3, block 1. So that could almost fool you into thinking it's a Winky Bach, except you don't get progressively longer P's. So what happens in Mobitz 2? Mobitz 2 is all the PRs are equal. So if there is a P and a QRS for that heartbeat, on the whole strip, all the PRs are the same. They're not getting longer, they're not getting shorter, they're not all different, they're all the same. So if there is a PR, they're all the same. But then there's just going to be some P's that are blocked. So for instance, you might have like a couple of beats that conduct, like 1, 2, but then over here you got a P that didn't make it and a P that didn't make it. And then you have a couple that make it. 1, 2, these two conduct. So when you see a Mobitz 2, you got a lot of gaps with P's in them. And this time you could even have more than one P alone in the gap. You can have more than one in the gap. You might only have one, but you could have more than one in Mobitz 2. So you could start having some big spaces with no pulse. We call that a high-grade block. And when you start to have more blocked P's than conducted P's, we say that's a high-grade block. That's bad news. So you really need a pacemaker at that point. So our plan for Mobitz 2 is to have a pacemaker available for this patient. If they have very few blocked P's and their pulse is actually pretty good and they don't really have any symptoms, we don't have to turn it on, right? We could put them on a temporary transcutaneous pacemaker, or we could even have the physician threaded a transvenous pacemaker, but it's on demand and it will only pace if they start having a big gap. So it doesn't mean they're going to be dependent on it all the time, but the plan for Mobitz 2 is they have to go to a unit where they can be paced. Because worst case scenario for Mobitz 2 is that you get something that has no more QRSs and just a bunch of P waves going by. So we know that could happen at any time, and that, so I don't know if you heard, but that's really bad, nothing but P waves going by. That's what we call, we have a word for that, in ICU, we call that no bueno. Nothing but P waves. Okay, so that's Mobitz 2. And there's all different patterns. So some Mobitz 2s don't look that bad. Like they could conduct 5, block 1, conduct 5, block 1. And they're not very symptomatic. And at first glance, if you only have a short strip, you might not even get one that has a gap on it. So you have to be really watching their rhythm. But if they have Mobitz 2, they have to go to an area where they can have a pacemaker. So that's been the policy at every facility I've ever worked at. And how you're going to know it's Mobitz 2 and not Winky-Bach and not third degree. So first of all, anytime there's gaps with P's in it, it's either Winky-Bach or Mobitz 2. That's the only ones that have gaps with little P's in it. And then, how do you tell the difference? You measure the PR intervals right next to each other. If they're the same, it's Mobitz 2. If they're getting progressively longer right next to each other, it's Winky-Bach. That's all there is to it. Moving on to third degree. All right, third degree block, no impulses are going to make it from the top all the way to the bottom. Not one. Somewhere in here, there is a total blockage occurring. Maybe you had an MI, you just infarcted a whole big area. And so now every time electricity comes down and hits this area, it never makes it past this point right here. So then a backup escape rhythm has to start from below this point. So you have two completely different things happening inside the heart, right? So I'm going to tell you about the most common morphology of third degree, but I'm going to let you know that there's really two different looking third degree AV blocks, and then you're going to know more than like 90% of nurses in the hospital. That's going to be a little present from me to you. So I'm going to tell you about the third degree block that everybody knows about, which is third degree block with a ventricular escape. So a lot of people have an MI and they infarct a big part of their ventricle, like their left ventricle. So let's say down here somewhere, they just infarct a whole big area, and this is all out. And there's no electricity getting past here. This is bad news. I told you this is bad. So the sinus node doesn't know, and it fires, and the electricity spreads, and the atria contract. They're all happy. They don't know what's up. And then you have atrial kick, and it all goes down to the AV node, and the AV node shoots it down the bundle branches, and it's all good until here. So you get a normal P, right? And then the sinus node resets, and it gets ready, and it just fires again for the next time. So you have P's going along. Atrial activity is normal. Actually, let's make them more frequent than that. So you have atrial activity going along at a rate of 60 to 100. As far as the sinus node knows, everything's great. As far as the AV node knows, everything seems great. It's just doing its job, everything's good. Down here in the ventricles, things are not so great. No electricity is ever getting past this point. So down here somewhere, these cells in this area that are not ever receiving any electricity, you might have a ventricular pacemaking cell with some automaticity, and as a backup pacemaking cell, it decides to start a ventricular escape rhythm for you. But it can only go really slow at a rate of 35, let's say. That's its intrinsic rhythm, a rate of 35. And because you've missed the entire conduction system, the QRS that you're going to get has to go cell to cell to cell to cell to cell, and it goes backwards up here a little bit, cell to cell. Has to go across the septum over to the right ventricle, cell to cell. Oh, it zips a little bit on this bottom part here. Cell to cell, you get like a notch or something weird in the shape because of that, cell to cell to cell. So you get something that's wide and bizarre, maybe like a notch in it. That's a ventricular looking QRS. And the rate is slow. It's going to be on the same line with these P waves, but it doesn't have anything to do with these P waves at all. But it's on the same line. So you're going to get like wide and bizarre with like a notch and then a T wave in the opposite direction. And maybe one right here. And maybe one right here. And maybe one right here. Okay. Then you can't see wherever this is laying on top of other stuff. Okay. So you have two things happening on the same line. P waves and QRSs. The P waves are going very fast, the QRSs are going much slower. They're totally dissociated from each other. They don't see each other. None of the P's are causing any of these QRSs to occur. It's complete dissociation. It's really P waves and a ventricular escape rhythm on the same line. That's third degree AV block with a ventricular escape. So that would be when the damage, where the block is down in the ventricle somewhere. What you're going to see when you look at the strip is you're going to be like, wow, this person looks terrible. I mean, it's regular, but their heart rate's like 35, and they got these big, wide ventricular looking QRSs. I mean, is there a P for every QRS? Kind of like, who cares? Let's go down to the room and see if they're even conscious, or do they have a pulse? Should I start CPR? Should we get the crash cart? Because this is like maybe not even life-sustaining. They might have a pulse, they might not. Sometimes when QRSs get really wide and bizarre, it's not even enough squeeze to generate a pulse. So you got to check and see if they even have a pulse. And even if they do, is it enough to sustain life? Should you maybe even do some chest compressions? If you were to measure PR intervals, what you'll find is they're all different from each other. So this one, like, maybe is normal. This one is like almost part of the QRS. So is that one, and this one's going to be long. There's going to be some P's like in the T waves, inside of other waves. That's how you know it's third degree block and that they don't even see each other. So that's third degree with the ventricular escape. There could be, and this is the one everybody knows, third degree blocks with ventricular escapes are very obvious, and they're usually an emergency. And the treatment is, like, we call a code. Sometimes you're even doing chest compressions, and we put this person on a pacemaker. Pacer. Probably the one on the crash cart is the first one we're going to put them on. And then they probably have this because they had like a big MI, is most of the time is what happened to them. But they could have also had a trauma of some kind, blown out a heart valve, or had an electrical shock. But usually it's a big MI is what happened, or a valve trauma is the next most common one. Okay, so everybody knows this. But there is one other type of third degree block that I have actually seen I don't want to say many, but quite a few times in my 25 years as a nurse. And every time I see it, I feel like I'm in the freaking Twilight Zone because I can't get anybody to understand what I'm talking about. But now I'm a teacher, so I'm going to teach it to y'all so that there's other people in the world who know what I'm talking about. I mean, the cardiologist knows what I'm talking about, but I can't get other nurses to know what I'm talking about. But now I have you guys, and you will be my people, and you will know what I'm talking about. You could have the damage to your heart be up here above your AV node. So this is probably not a heart attack. This is probably a trauma, like a motor vehicle accident, or a gunshot wound, or a knife to the heart. Yeah, so these things we definitely have these types of patients. So if this happened, the sinus node is sending down impulses at a rate of 60 to 100. So you're going to have your P waves just on the line going by. That one's getting kind of worn out. Let's do this one. You got your P waves going by at a rate of 60 to 100. Okay. Then the AV node is never getting any electricity. It's waiting, it's waiting, it's waiting. It's never getting anything. So what is it going to do? You already know. It's going to start a junctional escape rhythm. And the most common junctional escape rhythm is a flat line with a normal looking QRS, right? Because it's going to travel the normal bundle branch system at a rate of 40 to 60, but it even could be a little bit accelerated if you have a little adrenaline. It's going to be on the same line. So it's going to be some skinny QRSs and T waves. Oh, they're getting fat. Let me skinny them up. Okay, on the same line. Where two waves are right on top of each other, sometimes you get a taller, like super wave. So you get like an extra peak on top. Here you're going to have like this weird thing that's coming up and pointy in the middle there. You might get like a thing hanging off of that. Here you're going to have a lump on the side. You might have some kind of weird lump thing on that. Might get a lump there. Might get a lump on that. Double lump T. All right, so when you first look at it, it's going to look a lot like sinus rhythm because you got skinny QRSs, but maybe it's a little bradycardic. Maybe it's in the 50s. And then you're like, is there one P for every QRS? And then you're like, what? So you start measuring it and you're like, what happened to this T wave? Why is it like got this double hump thing? You measure that and you're like, that's normal. For some reason, that one's slightly longer. That one's ridiculously long. And then why is that lump on there? And why is there a T in between the QRS? Or why is there a P in between the QRS and the T? And then that one's actually shorter than that one. And that one's even shorter, and that's shorter, and then there's an extra lump on that and there. So all the PRs are different, and there's a bunch of P's like on other waves. That's the hallmark of a third degree block. Just P's all over the place, PRs all different, P's on other waves. That tells you that they're moving at two different speeds and they're not related at all. Total dissociation from each other. But it's the skinny QRSs that throw people off. This is third degree block with a junctional escape rhythm. And it just means that the damage to the heart where the block is above the level of the AV node. And if you don't totally get what I'm talking about, you can just tune that whole part out. As long as you understand third degree block with a ventricular escape, you're in tune with everybody who works at every hospital in America. And you'll know how to call the code and put the person on a pacemaker, and then that's fine. But if y'all want to be come have lunch with me at my house, then you need to know about this because that makes you special in my book. So, yep. All right, first degree, they're good. Second degree, Wenckebach, they're still pretty good. They can stay on the floor. It's the most fun. Mobitz 2, we start getting down into the bundle branch system. In fact, the QRS can even start getting a little bit wide. Third degree block, definitely can start getting down into the ventricles. Third degree block of the ventricular escape is usually a code rhythm. It is the most common type of third degree block. And you want to think PRs are all different, but then remember you can't have a third degree block with a junctional escape. All right, that's blocks. We'll look at mini strips together in class. One more to go, and that's ventricular rhythms.